Hi, I'm Steve Sulkes. I'm a developmental behavioral pediatrician from Rochester, New York, and I work at the University of Rochester. And I've had the good fortune to have served as president of AADMD in the past. Okay. Uh, One of the questions I've been asked is how I got involved with the population of individuals with intellectual and developmental disabilities. It's a fun story, so I'll share it because it may have relevance for you. Okay. I went into pediatric residency in the late 1970s with a plan to become a primary care pediatrician. That was my goal. Uh, I was doing my training in Syracuse, New York, which happened at that time, and still to some degree, to be an avant-garde hotbed of advocacy for people with developmental disabilities. So I was hearing a lot about this population in a way that I had never heard in medical school. And I sort of began to think about this population as a group that appealed to me to work with. And then my wife was planning to do subspecialty training. So I said, I'll put off primary care for a little while. I'll do a little subspecialty training in this area, can make it sort of a focus for myself in my primary care practice. That was the plan. I had the additional good fortune to nail a fellowship at Boston Children's Hospital with the late Alan Crocker, also trained by Dr. Leslie Rubin. And the two of them were amazing humanists. The team there at the Developmental Evaluation Center for my fellowship taught me so much about developmental disabilities and so much about people with developmental disabilities as humans. And this was life-changing for me. Dr. Crocker convinced me that I should not go into general primary care, but needed to focus more specifically on this population for my career. And I was a very obedient person, so I began looking for jobs in developmental disabilities. My first move out of fellowship was to come to Rochester. My wife was from here, and the job that I was able to get was an institutional primary care medicine job at Monroe Developmental Center. Was working there, and I had done some institutional work as a fellow, and it became increasingly clear to me that this was not going to be my future and that I needed to do everything I could to help get people with developmental disabilities served in community settings. I got lucky yet again, and a job opened for me at the University of Rochester, Strong Memorial Hospital, now Golisano Children's Hospital. And I joined the faculty there and have been there ever since, mainly as a clinician and as a teacher and a little bit as a researcher. My research actually has always been related to how healthcare is provided to people with intellectual and developmental disabilities, because I think improving the healthcare system for that group has been a challenge forever. It's getting better and better through training and through other efforts, but it's still not all we would like it to be. And that has been my focus. That focus brought me into interaction with the people in AADMD, and I found a home there that has been so enriching for me. I so much appreciate everything that I've had the opportunity to do with my friends and colleagues through that organization. So I'm a developmental behavioral pediatrician. And for those of you who don't know, there are two very similar related subspecialties. One is called developmental behavioral pediatrics, where you do 3 years of pediatric residency and then 3 years of fellowship in developmental behavioral pediatrics. There's another track that you can do called neurodevelopmental disabilities, where you do neurology training, then child neurology training, and then you do a year within that same 6 year span that focuses on people with developmental disabilities. And I actually had, because I'm old, I was able to get boarded in both of those, but my practice and my career have more focused on the developmental behavioral side of things. So what is developmental behavioral pediatrics? It is a subspecialty of pediatrics that focuses on diagnosis and ongoing care of kids, especially, definitely youth, but sometimes adults who have intellectual and developmental disabilities. So we are the people who are diagnosing ADHD and autism. We work with kids with cerebral palsy and spina bifida and Down syndrome. We do follow-up of babies coming out of the NICU, and we provide similar services as kids go forward. When I told my parents that I was going into this subspecialty, they said, "What are you going to do?" And I said, "Well, I'm going to be a little bit of a neurologist, a little bit of a psychiatrist, a little bit of a geneticist, a little bit of a psychologist, a little bit of a rehab doctor. Okay, and I'm still going to do some primary care because I love doing primary care. And it's mostly going to be with kids, and it is practically always going to be as part of an interdisciplinary team because that's how we do this. We have to be able to learn from our colleagues, share what we learn with our colleagues, and to serve people well, work as a team. So that's what we do. I've had the good fortune to be a director of a LEND program, which it's a great example of one of those interdisciplinary approaches. LEND stands for Leadership Education in Neurodevelopmental Disabilities. And the LEND program in Rochester is now, I think, in its 27th year, training people in 13 or more clinical disciplines, all related to developmental disabilities. LEND programs are great. If you are thinking about studying developmental disabilities more in your career, look for a LEND program because it'll really round you out and give you all kinds of good extra skills and turn you into a leader, because that's what the L stands for. Okay. Another question for this recording was, how do we make healthcare more inclusive for people with intellectual and developmental disabilities? And one of the questions was about, one of the examples was about using people first language, and we should always use people first language unless the person we're talking with prefers disability first language. There are people in the disability community who do that. So this is an example of ask the person what he or she wants. Just as we're asking about gender preference language, about cultural or ethnic definitions, people define themselves, and we need to ask, how do you want us to refer to you as a person with developmental disability or using disability first language? I've worked with people here in Rochester who have helped to craft an office environment that is very friendly to people with developmental disabilities, from the perspective of physical environment, of sensory experience, and from communication perspectives. We take advantage of all of those to make sure people understand and feel comfortable coming into our clinic. And that's also key. It's very important. You're going to find a way to do that in your practice. However, the thing I really want to convey today is the importance of having an attitude and conveying to your patients that you have this attitude of taking people as they are. We live in a world that's diverse, and that diversity implies that we should not make assumptions about people. And part of that diversity is neurodiversity. So we need to accept that people are who they are, that they are living their lives as they're living them. And then we want to find out what their goals are. How can we help them achieve those goals? And they might be health goals. And if they're health goals, that's great. That's why they came to us. But they might also be other life goals that being healthier could help them achieve. So find that out from people. Ask people what they want to, what they need from you and what they want you to help them get. And sometimes they won't even realize you can help them. But so you say, well, they want to be healthier, they want to lose weight. It might be that having better oral health could help them be healthier in other ways, improve in terms of diabetic care, for example. My point with this is that our colleagues in the world of healthcare communication say we're going to be most effective when we find out what the goals of the patient, or maybe the patient's circle of support, but especially the patient, the individual we're serving, are, without making assumptions. Because we may come into the interaction with assumptions about what they need that completely miss, and then their time has been wasted, our time has been wasted. Much, much better to find out what people want and then try to get them that. And if you can add in your own agenda to that, that's great, but make sure you're meeting their needs first. I am in Rochester, New York. My email address, if you want to reach me, is ssulkes@gmail.com. And I would love to have you reach out to me with questions or feedback. And I wish you well. Thanks.